Hello, everyone. Thank you for joining us for this webinar on HCC coding, capturing and reporting risk in your patient population, a key to success under value-based arrangements. My name is Cassidy Avila. I'm the program coordinator for the Texas A&M Health Rural Engagement Program. And before we begin, I have just a couple of housekeeping notes for you. We are recording the webinar and we will make a copy of it available as well as a copy of the slides. And we'll send that out through a follow-up email from the Rural Engagement Program within about 24 to 48 hours after the presentation. If you would like to drop questions into the chat box, we will have time for Q&A at the end, and I will comb through those and pose any questions that are left there to the speaker. You also have the option to unmute or type those questions into the chat when the presentation is finalized and during that time. You can find the chat box on the bottom toolbar of your Zoom window. Just click the drop-down arrow and either select everyone or my name. Either one will work to get your question out there. It is now my pleasure to introduce our speaker, Carine Leslie, Senior Manager with PYA. Carine serves as a Senior Manager on the firm's Revenue and Compliance Advisory Services team. He's a subject matter expert in ICD-10, CMPCS, CPT-4, inpatient, hospital, outpatient, physician evaluation and management coding, and clinical documentation improvement. Her inpatient experience ranges from inpatient acute medical and surgical to rehabilitation to behavioral health. Carine's outpatient experience spans outpatient surgical, ancillary services, drug administration, ED, observation, behavioral health, and E&M. Carine is a registered health information administrator, a certified coding specialist, and a member of the American Health Information Management Association, as well as the Georgia Health Information Management Association. Thank you for being with us today, Carine. We're honored to have you. It is all yours.
Thank you, Cassidy, and good afternoon or good morning to those, depending on where you are located. As Cassidy stated, my name is Carine Leslie, and I am a Senior Manager here at PYA. Our goal today is to just discuss hierarchical condition category coding, or HCCs, as I will refer to it throughout this presentation. And so I will go ahead and get started. So my goal during this presentation is just to provide a brief overview of Medicare Advantage or risk-based reporting, what it is, how reimbursement is determined as compared to fee-for-service, because I think it's important to understand the difference and how services are reported and how reimbursement occurs under those two different plans. I'll touch on how HCCs have changed for 2024 and the future. The meat of the presentation and what I think everyone is here to learn more about is covering coding and documentation for HCCs. And lastly, I'll cover some recent government activity that has happened in the last year and what compliance should be focused on for your organization in relation to HCCs and coding and documentation. Again, I won't do a reintroduction of myself, but as Cassie had explained, I just have a focus on revenue integrity and the impact that it has to organization. My expertise is a range of coding and documentation, all patient types, settings, reimbursement methodologies, and HCC has a special place for me because I understand how that reimbursement occurs, the importance of the coding and documentation, and the importance of making sure that as an organization that is being reimbursed under HCCs, how to get that right. If you're not familiar with Medicare Advantage, it is Part C of the Medicare program. The whole purpose and goal of it was designed to allow for private industry commercial payers through approval from Medicare to take part and administer Medicare programs. MA plans as a whole, they provide Part A and Part B coverage for the various plans, either through an HMO or through a PPO or other various types of plans. And so their goal is to be able to provide services to a certain patient population outside of the traditional fee-for-service Medicare plan that we're all familiar with. So this graph here, I think, is important to understand just how Medicare Advantage has changed over the years. The availability of Medicare Advantage plan options have changed over the last 14 years. You'll see for 2024, the average Medicare beneficiary has access to 43 Medicare Advantage plans. which is the same amount as 2023, but it's more than double the amount from the period of time that was reviewed going back to 2010. These numbers do include certain types of plans that are considered under Medicare Advantage, so they're only covering the HMO and PPO plans. As of right now, as of 2024, there are over 3,900 Medicare Advantage plans available nationwide for individual enrollment, and which is slightly down from 2023. But if you look at the graph and the number of Medicare Advantage plans that were available to beneficiaries, it is the second largest year where Medicare Advantage plans are available. In addition to that, as I had stated earlier, their Medicare Advantage plans do have HMOs and they do have PPOs. HMOs take up for about 50% of the plans that are offered to beneficiaries. Some interesting facts about Medicare Advantage plans is that though there are over 3,900 plans available for people to select from, on average, there is a slight decline in the number of Medicare Advantage plans for certain states and certain counties. The states that have the most decline are actually Alabama, Illinois, and Texas, Texas currently has 16 fewer plans this year than they did the previous year. And then the beneficiaries on average have about 49 plans available to them to select for 2024, which is a little bit lower than 2023. Which had 51 plans available. The interesting thing is depending on where a beneficiary is located, whether they are in a metropolitan area versus, a smaller city or a more rural area, the percentage or average number of Medicare Advantage plans that are available to that beneficiary drastically changes. For example, if a beneficiary is in a city that has over 50,000 people, they have on average 47 MA plans available to them. So you think of that option for those patients and the providers that will be seeing those types of patients. As compared to a smaller city or a rural area, they have about 27 plans available to them for selection purposes. And so the impact of Medicare Advantage plans across the country depends on the location of that patient, but you think about the providers that are also impacted as they make sure they get this information correct. If you're considering or thinking about, MA plans versus the Medicare fee-for-service or the traditional Medicare as most of us know it, there are differences in how providers are paid and how the plan is funded. First, let's talk about how providers are paid. Under the fee-for-service plan, the CMS is based on procedures that are performed. So there's CPT codes and HCPCS codes that are utilized to reimburse providers, while providers in the MA plan are paid either based on the procedures or based on the risk-adjusted capitated model that they have. And that depends on the contract that provider has with that specific MA plan. Additionally, under the MA program, CMS makes, advanced payments to the MA plans for their specific beneficiaries. And there's some requirements under that as to how the payments are made, how they anticipate the cost, what is taken into account for anticipating the cost, and understanding that the cost for that Medicare beneficiary under that MA plan cannot be significantly or drastically different than what it would have been under the Medicare fee-for-service plan. In order to really understand the Medicare Advantage plans, you have to understand the principal components of the Medicare Advantage plan. So in order for the Medicare Advantage plans to determine payment for each of the beneficiaries that are within their program and part of their HMO or PPO plan, there are two principal components they are using. Those two principal components are the base rate and the risk score. CMS calculates that risk adjustment payment to that Medicare plan based on these two components. The first one is the base rate. The base rate that CMS sets is essentially determined by bid amounts from that MA plan. The risk score is what's impacted by the provider documentation, by the ICD-10 codes that are submitted, and by that overall beneficiary's health status and other components. That beneficiary's health status is used for the purpose of calculating the overall risk score. CMS takes the diagnoses that are submitted to that beneficiary from acceptable provider types, such as physicians and hospitals, They collect the diagnoses that are submitted on those claims based on the information that provider submits on the claims from their medical record documentation to determine reimbursement. CMS has a whole methodology for determining the risk score. They map their diagnosis codes to specific HCCs or hierarchical condition categories based on clinical characteristics of those diagnoses and the severity and the cost implications to those conditions. For example, patients with diabetes, if you have acute diabetes, chronic diabetes, or an unspecified type of diabetes, they consider that to be of the same clinical characteristics, severity, and therefore the costs related to providing care to patients with diabetes would be the same. Each HCC score also has a risk adjustment factor number that's assigned to it. If you're familiar with DRGs or you're familiar with, the wage index or anything of that sort, it's the same type of methodology. So an HCC, let's say for 19, may have a risk adjustment factor score of 0.8. And so that in itself provides a risk score for each patient or each beneficiary that's part of that plan. In regards to reimbursement under the risk adjustment category versus the fee-for-service, risk adjustment program is prospective. The reason it's prospective is essentially what CMS does is it uses the diagnosis codes that the beneficiary receives in 1 year, known as the service year, to determine the HCCs and calculate the risk scores for the following calendar year. For example, the risk scores and the reimbursement that's being received in 2024 was determined based on diagnoses and HCCs that were calculated in 2023. Enrollees' risk scores can change from year to year. They can go up, they can go down. It all depends on the health of the patient and, of course, the submission of the diagnoses codes by the providers on the claim. Risk scores while they can increase or decrease, it is important, and we'll talk about this a little bit later, but providers understanding the importance of the submission of the diagnoses codes is something that I think providers need to be educated on, and they need to understand and learn that. The risk adjustment programs do compensate the MA programs for any potential additional coverage or additional things that are identified throughout the year that may not have come up in the previous year. But essentially, there's a base payment that's a monthly payment that's coming to the MA plan from CMS based on the diagnosis codes that were submitted before. So in 2024, CMS made some significant changes to their HCC program. They finalized and updated the risk adjustment model for 2024, but as they have done in previous years, they're phasing it over a 3-year period. And so each year, starting with 2024 through 2026, there's an adjustment on how they are calculating the risk score. And essentially, they're using 2 different models. They're going to be using the 2020 model, which is based on, different diagnosis coding category and different methodology in combination with the 2024 model, which will cover how the differences are here. So the phase-in approach is taking into account in 2024, we'll use about 33% of the new model and 67% of the old model. And the goal is by 2026, all of the patients that are under an MA plan and that are being all the plans are being reimbursed for MA services are under the new model in 2026 and being calculated using the 2024 model. So let's talk about what the 2022 model looked like, why they made the decision to make the adjustment to the 2024 model, and what the impact is overall. So the previous HCC model was based on the 2020 model, which was based on ICD-10 codes. And if you're familiar with diagnosis coding, ICD-10 codes were replaced, or ICD-9 codes were replaced with ICD-10 codes in 2015. And that was a significant impact from the types of services and types of codes that were being captured. So essentially what CMS was doing from 2015 to 2023 essentially is that they were mapping ICD-9 codes to ICD-10 codes or vice versa to determine the HCC categories and the risk scores for each of their patients. The reason for doing that is that CMS was waiting for ICD-10 coding to stabilize in order to determine what changes needed to occur. And so for a period of 9 years, they were remapping those services. So in 2024, CMS undertook reclassification, which involved building new condition categories from the ground up, reviewing each diagnosis, determining the best group that they should belong in, determining the diagnosis to be whether it's clinically sound, if that is a condition that impacts or predicts Medicare cost. And they did that over a period of years. And the goal for updating the data was to reclassify some of the conditions. So you can see under the 2020 model, they were mapping it to all of the ICD-10 codes, but you can see that the HCC categories under the 2020 model versus the HCC categories under the 2024 model, there was a significant reduction. And the reason that occurred is because what CMS did in kind of revamping and redoing the HCC model, they grouped a lot of the services. They considered, for example, diabetes is a common HCC category that has been around for a period of time. Under the 2020 model, diabetes had 3 different HCCs. There was one for an unspecified diabetes, there was one for chronic, and there was one for an acute diabetes with an acute condition. What CMS essentially did for 2024 was to say, the services that are provided to patients that have diabetes, whether that's with an acute condition, a chronic condition, or no condition that's impacting the diabetes, we are saying that the care and the cost of care for those patients is the same. So they essentially bundled all diabetes into one HCC category and kind of rephrased that. In addition to that, they removed a lot of ICD-10 codes from being able to be risk adjusted. You can see it's over 2,200 codes were removed from being risk adjusted, and we have a list of some of those conditions in the coming slides. And then the last component was they added some diagnosis codes. As they were reassessing diagnosis codes under ICD-10 and what was available, there were some differences there. So ICD-10 is more specific in the diagnoses that are being selected. And so what they did was say, looking at the clinical indicators and the cost of care to patients and the cost of care to the Medicare Advantage plan, how do we determine or identify diagnoses codes that should be included and should be risk adjusted? And they added 209 diagnosis codes to the current model. As part of the process for the ICD-10 transition under this 2024 model, as I stated before, CMS essentially decided that we're going to remove 2,200 codes. We're going to add 268 new diagnosis codes that map to an HCC. We're increasing the number of HCCs we currently have from 86 to 115. And then we're doing that all because of the greater specificity that ICD-10 offers. The mental health diagnosis codes are another common area that were very different under ICD-9 versus ICD-10. And based on the analysis that CMS did in reevaluating this payment methodology, it resulted in remapping of these diagnosis codes for mental health conditions. As part of the revision, you can see some of the conditions that were removed. They have acute kidney disease, they have PVD, they have amputation of the patient's toe. And you probably have heard the story of, HCCs, because every year a patient starts over. The example that's commonly given is if a patient had a toe amputation or they had a leg amputation that occurred in 2023, once 2024 appears and starts, you assume that all of those limbs have grown back. And so what CMS has done is to say there are some conditions that we see are a big impact to cost of care and predicting cost of care to the MA plan, but there are some that are not. And so they've removed some of those categories. They've essentially indicated that this occurs because the clinical indicators have become more broad. And so there's no need for significant interpretation of the condition. Providers have gotten better at identifying certain conditions and diagnoses and documenting them. And so they've indicated that the clinical significance for these certain conditions do not impact the patient care or treatment or management that is required under the ICD-10 coding guidelines. So now let's jump into the meat of the presentation, and you'll hear me refer to MEAT as an acronym that's utilized for HCC coding and documentation. And the reason that I refer to it is it's an important aspect as you are educating, whether that's yourself, your team, or your providers within your organization. It's a good acronym for individuals to understand and know, specifically because it helps them understand when a diagnosis code should be submitted versus when a diagnosis code should not be submitted on a claim. So HCC documentation requirements. HCC's CMS, they do have an auditing methodology, which is a risk adjustment data validation audit. And there are specific requirements that they are looking for. In addition to documentation to support the diagnoses, documentation should indicate the patient's name, the date of service on all of the pages of the record, which, a few years ago, maybe 10, 15 years ago, that was a problem when you were utilizing paper records. That is no longer a problem utilizing an EHR. In addition to that, that service must be from a face-to-face encounter. While we did go through the period of COVID and we had telehealth visits, those were still considered face-to-face visits, whether that was a video, conferencing, a video type of Zoom or FaceTime or anything platform that was being utilized. An HCC service, in order to be supported and submitted to a payer to support the HCC to the MA plan, it has to be a face-to-face visit. And of course, there's got to be documentation within the medical record of the provider that is clear, concise, consistent, and complete. We don't necessarily have the issue of legibility because of EHRs, but it used to be an issue 10 or 15 years ago. And then, of course, each documentation that is submitted for HCC purposes has to have a signature from a provider and their credential and the date that it was authenticated. This is not only an HCC requirement, it is an overall CMS signature requirement, but it's one of the factors as the plans were being audited under the OIG work plan in the past year that was being considered and reviewed. So there are all sorts of documentation that can be utilized for HCC purposes. It is not solely an inpatient encounter. It's not solely a provider, practice note. There's tons of documentation that can be utilized because there are a lot of face-to-face visits that occur for patients. So that documentation can come from an inpatient visit at a hospital or critical access hospital, a rural health clinic, an FQHC, an outpatient hospital setting, a provider practice. So the documentation for HCCs can come from multiple sources. But you'll note that there are certain services that are excluded, while some may be face-to-face visits. CMS has indicated that those types of patients, the service that's being provided, the setting of the service does not support HCCs. So skilled nursing facilities, radiology services, and ASC services are not reported to Medicare Advantage plans, and therefore their diagnosis codes are not reported for HCC purposes in capturing. It's important to note that because there are patients that are seen within the skilled nursing facility and the majority of their care is provided within that skilled nursing facility. There are patients that go to the ASC to have procedures that are performed, and while the procedure performed within the ASC is the claim reports the diagnosis code, those diagnosis codes are not reported to the payer. And so if that condition is still impacting the patient at a post-op visit or a later visit that the patient may have a follow-up visit that's 6 months later, it's going to be important for providers to continue to support that they're treating the patient for that condition and billing that ICD-10 diagnosis code on the claim out to the payer. So HCCs, providers play the biggest role in all of it. While from a coding perspective, you want to make sure you're submitting the proper ICD-10 codes on the claim, the providers play the biggest role. The reason for that is that the providers need to make sure that they are documenting clearly and completely the condition that they are addressing and they are treating for that patient during that encounter. So as you can see on the slide here, providers that are responsible for reporting their ICD-10 codes should understand the importance of complete diagnosis code submission. Some EMR systems that are built out for providers do have drop-down menus that you can select the diagnosis codes, and sometimes, providers having to see the number of patients that they have to see in a day. are not as detailed in their code selection. And so therefore they might select an unspecified condition, such as an unspecified chronic kidney disease versus a more specified chronic kidney disease. And I do have a slide later on the comparison to that, but it's important as you are training and educating providers that are responsible for selecting their diagnosis code, the importance of making sure that they are selecting diagnosis codes to the highest level of specificity. So when you think about a patient visit, a patient comes into the practice, they come into the critical access hospital, they go to an outpatient clinic, wherever they are being seen, there's typically a workflow of diagnoses. If you think of it as a funnel, the patient comes in, they have a list of issues that are going on, whether those lists of issues include chronic conditions or acute conditions. So it could be the patient has hypertension, but they also have an upper respiratory infection, and they also have, diabetes, and they also have congestive heart failure. The provider is kind of assessing at a high level, what are all of the problems that I will need to address for this patient during this visit? So that is essentially the problem list. Where do I start for all of the things that are going on? As a provider works through the visit, they eventually get to the assessment and plan. And in the assessment and plan is typically where most providers are documenting the diagnoses that are being handled by them as the provider that's seeing them, whether that's their primary care provider, their cardiology provider. But they're also documenting diagnoses that are being handled by another provider or that they are referring the patient to. And therefore, clearly documenting what they are assessing and what they are treating is going to be important. Then you have reporting on the claim. The claim should only include the diagnoses that are for the reason that patient is being seen during that visit and that are pertinent to the decision-making for that visit. And that's why I think of it as a funnel, because as you work through that diagnosis determination on what should be reported on the claim, it eventually gets to a point where, yes, I'm addressing 4 of the 6 conditions for this patient today. I'm not addressing the other 2 from a provider perspective. And therefore, if I am not addressing the other 2 conditions and they are just FYI, the patient does have this condition, or FYI, their cardiology provider is assessing the congestive heart failure they may have, or the endocrinologist is assessing the hypothyroidism that patient may have, then essentially that provider should not be reporting that diagnosis code on the claim. Then eventually you get to selection of the E&M service, which depending on the MA plan that a provider is utilizing, then that E&M service will determine what diagnoses are being assessed and leveling that E&M service. And so I did mention E&M services because if you're not familiar with the guidance that has changed over the last 3 years or so, the E&M guidelines changed. And one of the major things that they did in that change is providing a definition to providers on problems that are being addressed. And the way that this ties back to HCCs is important. And it's actually critical because the providers are learning and being educated on leveling an E&M service. What problems are you addressing? What problems are you referring the patient to another provider? What problems are impacting the level of E&M service that you are billing? HCCs kind of take a similar approach into how they define a diagnosis code that should be reported on the claim, a diagnosis code that would support an HCC. So I mentioned it earlier, the acronym MEET, which stands for monitoring, evaluating, assessing or addressing, and treating of a condition. The documentation from an audit perspective, from a coding perspective, this should be the mindset for providers, for coders, for individuals that are responsible for submitting ICD-10 codes on a claim for HCC purposes, and for all purposes across the board, not solely for HCCs. So as you look at a provider documentation, it may not always be in the assessment and plan, it might be in the history, it could be in the exam, but diagnosis codes can be pulled from multiple components of the provider's medical record for that patient. But what's important for the provider to understand, or a coder to understand, or any individual that's responsible for submitting codes for a specific claim, is understanding that if you are submitting a condition, it has to meet one of these requirements. It does not have to meet all 4. The condition does not have to be monitored, evaluated, assessed, and treated. The condition only needs to meet one of the 4 letters of the MEET acronym. So for example, a patient comes into the provider practice, they're being seen for their annual assessment or annual visit, and the provider is, checking up on all of their conditions. So their hypertension, their diabetes, their congestive heart failure. This is their primary care provider that's kind of assessing all of these conditions. So they've taken the patient's blood pressure, they've looked at the medications that the patient is on for all of these conditions. They've confirmed that they have, their follow-up appointment with their cardiology provider. They may be refilling their hypertension medication because that primary care provider is responsible for hypertension. So they're assessing all of those conditions. They're describing if it's stable, if it's improved. They're also assessing if they need to refill their medication. So in that scenario I described, the scenario I described, the provider is assessing and also treating all of those conditions. But there may be instances where the provider is only responsible for hypertension, and he is not addressing the patient's, congestive heart failure. He's only addressing the patient's hypertension, but also telling the patient, you need to go ahead and schedule your cardiology appointment. In that scenario, the provider would report the diagnosis code for the hypertension as it relates to the congestive heart failure, but they would not report a diagnosis for congestive heart failure from an HCC perspective, because they would not be able to support that they have, monitored, evaluate, or assess that condition for that patient during that visit and during that encounter. ICD-10 codes play an important role, of course, because you have to follow the guidelines in order to submit an ICD-10 code on the claim, but also to make sure that you're reporting the codes as it applies for ICD-10 guidance. Providers in general do not have the time to read through the ICD-10 guidelines to understand the nuances of it, when you should bill, hypertension with CHF versus not billing it. They have to understand the basics of ICD-10 reporting. And so ICD-10 does have specific guidance on how to report diagnosis codes. It is very detailed and very lengthy guidelines that they have out there. But I think as we think about HCCs and we think about reporting for those services, it's the basics of understanding if a chronic condition is being reported and documented appropriately as the provider is addressing them. As long as they're receiving treatment, you would report that diagnosis code. If the patient, let's say, has a malignancy that is being addressed or treated by that provider, you would continue to report the malignancy code as long as that provider is treating the patient for that malignancy. But if a condition has resolved, let's say a patient had pneumonia 6 weeks ago and now they're following up, but their pneumonia has resolved, well, that's a condition that's no longer impactful and should not be reported on the follow-up visit as pneumonia. There are diagnosis codes specific for follow-up of pneumonia that is not that's not applicable for that visit, but it's a Z code saying the patient has had pneumonia previously and now they've healed from that condition. And so it's understanding when a condition is current and being treated currently during the encounter versus when a condition is resolved or it's a history condition that the patient is no longer impacting the care of the patient, and reporting those appropriately. Because at the end of the day, when you submit HCCs, you submit the diagnosis codes to the providers, you have to be able to support that diagnosis code to the MA plans and support the HCC that's being captured. And we'll talk about it a little bit later, but the OIG is doing a lot of audits on MA plans. And it's been eye-opening for providers. It's been eye-opening for the MA plans, but I think understanding when to submit a diagnosis code versus when not to submit a diagnosis code is going to be helpful in making sure that we stabilize the payments that are being provided to the MA plans. So just some coding and documentation goals. As I stated before, for each patient, every year that restarts, a patient essentially starts with a clean slate. They no longer have the diabetes. They no longer have a lower leg amputation. They no longer have all of the conditions that were reported for them in 2023. So as patients come in to see their providers within the various settings, providers should be documenting and assessing the current conditions, reporting them to their highest level of specificity based on their documentation, and only reporting one diagnosis code per category. And the reason I say that is because there are instances CKD and hypertension are a good one. CKD is a condition where you can have various levels and severity of CKD, but you can also have an unspecified version of chronic kidney disease. And so you want to make sure that you're only reporting one from that category. You don't want to say in January that the patient had end-stage renal disease, but then in July they suddenly have unspecified chronic kidney disease. Clinically, that doesn't happen. Typically, a patient that has end-stage renal disease will always have end-stage renal disease, but selecting the wrong diagnosis code can cause to question what conditions are really being treated for the patient, but also impact the overall payment to the MA plan and therefore impact the provider practice and or health system at the same time. One of the major ways that documentation and diagnosis codes are captured are during a patient's health status assessment. And we'll talk about the health risk assessment on the next slide. But typically at the start of the year, sometime between January and March, providers are having patients come in to do a full assessment of them, and they are looking at multiple conditions. And the reason for that is to make sure that patients are getting the care that they need, but also two, making sure you're capturing the diagnoses as a restart for the new year. There are EMR systems out there that can prompt providers to make sure you schedule the appointment for the patients to see them for their chronic conditions and documenting those chronic conditions and capturing them on the claims. And those EMR systems can be useful, but they can also cause issues or concerns as to making sure you're not documenting or capturing a condition a patient no longer has because it was resolved in the previous year. As I previously stated, patients will typically come in at the early part of the year for their health risk assessment. And essentially what it does, it creates a building block of the structure of how a provider is going to manage that patient for the year. So mostly providers will capture their chronic conditions, they'll look at everything that the patient has previously been treated for and determine what is still going on for the patient that's going to impact the patient this year versus what is no longer a condition that is going to impact the patient for the current year. And so the medical record documentation, as always, should continue to support the ICD-10 code that's being billed. So while the patient's coming in for their health risk assessment, the provider still needs to document the meat components of the conditions that he or she is addressing during that visit or any visit thereafter. And so this is just an understanding for the health risk assessment and why it should be completed and the guidance and the support behind that based on the ACA or the Affordable Care Act. It essentially states that HRAs are to be completed before as part of an annual wellness visit for a patient. Most people are familiar with annual wellness visits and the reimbursement for that and the magnitude of documentation that is needed to support the annual wellness visit. Providers are essentially being encouraged and supported to make sure that they're seeing their patients and assessing them on a regular basis, but that health risk assessment is part of that annual wellness visit, and in some instances may cause issues or concerns from a billing perspective for ICD-10 codes, because as I previously stated, providers are listing conditions that are no longer impactful or supported for the year that it is being reported in, and therefore sometimes reporting conditions and diagnoses as a later point. When you think about some common risk adjustment coding and documentation errors, some of these were things that were found during some of the OIG audits that they were doing for several of the MA plans in the last year. History of a condition essentially means from a coding perspective that condition is no longer present or the patient no longer has that condition. A lot of errors were identified for coding a condition as if it was active or present for that patient instead of coding it as a history condition. The alternative also, or the flip side of that also occurred as well, as providers were submitting diagnosis codes for history of conditions when that condition was still active, such as a patient having a history of hypertension. Typically, once a patient has hypertension, they will always have hypertension. If a patient has diabetes, they typically will always have diabetes. It doesn't suddenly disappear from that patient as from a management of that patient and care for that patient. The other example that was identified during some of the OIG audits was related to selecting a specified code versus selecting an unspecified code. What some of the OIG audit reports indicated is that sometimes the MA plans received reimbursement and claim information that specified, oh, the patient has CKD stage 4. And so they were reporting N18.4, which does risk adjust to a specific HCC. In all of the documentation that was provided and reviewed during those audits, in most instances, that CKD diagnosis was more of an unspecified code and therefore did not have a risk adjustment to it. And so, as I stated before, providers do have EMR systems that help them select their ICD-10 codes, and they do the drop-down menu. They select typically the first code that they're seeing, and they move on because they're trying to get through that component of it and the billing aspect of it so that they can continue to care for and treat their patients. But selecting the wrong diagnosis code can significantly impact the payment that's received to the MA plan and essentially provided to the physician and or nurse practitioner or PA that's treating that patient and the organization as a whole. And so from an education perspective, making sure providers understand there are differences in the types of diagnosis codes. There are differences in the specialty, specificity, the number of characters that are reported. There are differences there, so that they should pay attention to making sure they are selecting the diagnosis code that best represents what they have listed within their medical record and not really selecting the first one that's in that drop-down list. Some more common risk adjustment coding and documentation errors that were mentioned in some of the OIG audits. Sometimes the documentation does not always support the reason that the patient was there. So the chief complaint as to why the patient was there. Any coexisting acute conditions the patient may have, sometimes missing out on chronic conditions or reporting chronic conditions that were not documented as being assessed or treated for the patient during the visit. They may have been listed in the patient's past medical history or listed on a problem list, but there's no indication that the provider really cared for that patient related to that condition. And then not always clearly indicating the care that was provided. So if there are medications, where there are labs that were run, there are some instances that would support that HCC and support that diagnosis, but the provider didn't always clearly indicate that in some instances, or the documentation was not provided to that MA plan. So as we think about documentation tips for providers, what is it that they should focus on? Where can they improve from a documentation perspective? Where can they improve from a coding perspective? I think the best way to go about this is, one, educating providers on communicating within your medical record what you are doing, what you are addressing for the patient during that visit, and what's impacting the service that you are submitting from a reimbursement perspective as well. So if you think about providers clinically understand, they're seeing a patient, whether that's a primary care provider or cardiology provider, they are seeing that patient and they understand the entire care for that patient. They understand what they're doing, they understand what they're assessing, they understand the treatment plan that they're providing for them. From a clinical perspective, they understand that. What they need to get into the habit of doing is making sure that they are documenting that information within the medical record in a clear and concise way. So if they are assessing a patient for an acute condition, let's say the patient had an upper respiratory infection, but the patient also has hypertension and they also have hypothyroidism, and they're on medication for those two conditions, the provider needs to understand, while you may not be assessing and treating that hypertension during that visit, but the medication, you've looked at the medication, you've taken the patient's blood pressure, that impacts their upper respiratory infection that you are seeing the patient for. It impacts the medication that you might provide to that patient during the encounter for that infection that they have. And making sure that they are documenting all of the chronic conditions that are affecting the patient's management of care. In some instances, as I stated, providers understand all of the chronic conditions the patient has, all of the medications that patient is on impacts the overall care, but they don't always clearly document that within the medical record. They are focused on that primary condition that the patient came in for, they're focused on just that one condition and typically only report that one diagnosis code on the claim. But they need to understand that everything that they are considering in their treatment for the patient could impact HCCs, but it can also impact the diagnosis codes that are being reported on that claim. So the last thing I'm going to cover and touch on is just some recent OIG activity and compliance, and then compliance focus for organizations. So within the last year, there have been 31 reports, and they could be more from the time that I put this presentation together. But there have been 31 reports on the OIG site specifically related to targeted reviews of documentation supporting specific diagnosis codes. I've listed here a few of the payers that were impacted by some of the audits and some of the reports that are publicly available for viewing and reviewing through. I think the common theme that we have seen that I have seen in reviewing some of these OIG reports is just lack of documentation, whether that's lack of documentation within the medical record or lack of documentation of something that wasn't provided for the audit purpose. It's imperative and important that as you are reporting the diagnoses from a critical access hospital perspective or from a clinic perspective, that you probably consider implementing certain conditions and certain audit processes to have them in place to make sure that you are looking at diagnosis coding. I think a lot of organizations are hyper-focused on the CPT codes that are reported. They're hyper-focused on E&M codes that are reported. Diagnoses codes are important as well, especially if your organization has patients or is part of a plan that is risk adjusting based on diagnosis codes. In part of that audit, as part of the OIG work plan, the OIG did include 9 groups of HCC diagnoses that are at the highest risk for risk adjustment audit. I mean, you can see that for 4 of the 9, they include some type of cancer diagnosis. So lung cancer, breast cancer, colon cancer, and prostate cancer. And the reason for that, in the years that I've been doing coding and documentation, as you think about cancer as a diagnosis in itself, once a patient has cancer, typically doesn't go away. They do go into remission. I think what's difficult to understand is that there are diagnosis codes out there that support an active cancer diagnosis versus a history of cancer diagnosis versus a cancer diagnosis that's within remission. And what we find typically for especially lung cancer, breast cancer, and colon cancer is that typically providers are reporting it as if it is a current cancer diagnosis 4 years after the patient has been in remission or 2 years after the patient has been in remission and they're no longer receiving treatment for that cancer diagnosis. And that typically tends to be the highest error when we are reviewing for HCC purposes. The cancer diagnosis codes tend to be at the highest error. Because providers just don't understand that there are different diagnosis codes to support that they are seeing the patient for a 1-year follow-up on breast cancer after they've been in remission for a year, or 1-year follow-up after they've been cancer-free from breast cancer. There are certain diagnosis codes that are specific for that. The other one that's a pretty common diagnosis code or HCC category that's miscoded is acute stroke. And again, for that one, it's a patient typically, if they have an acute stroke that's happening within the inpatient hospital setting, the patient is hopefully not having a stroke within the clinic or office visit. And we find that typically when a patient has been seen within the hospital setting and then they go follow up with their provider a week or 2 after their discharge from the hospital, providers are billing out the acute stroke code, which is not accurate or appropriate because there is another code for a history of a stroke for a patient. And so these were just some that I thought were good to understand why they're high on the list for Medicare Advantage plans for audit errors, but also understanding how, educating providers, if you have oncology providers, educating them on the guidelines related to ICD-10 coding for oncology services. If you have cardiology providers or primary care providers that are seeing patients, educating them on the proper diagnosis codes for a patient that is post a stroke or post a heart attack. In addition to, listing the conditions that are at the highest risk for errors, CMS also created an OIG toolkit. for HCC services, and essentially they developed a resource that provides high technical information to assist the MA organizations so that they can start analyzing and looking at the risk adjustment data that they have and that they're receiving for their providers. It also helps them identify where the focus areas need to be, what conditions you need to look at, what diagnoses are tend to be at a higher risk for being miscoded, and then what actions that are appropriate to take. And while the toolkit was built for MA plans, I think that some provider organizations can get some valuable information from that toolkit as far as determining, what audits need to be incorporated into your organization for reviewing for ICD-10 coding and for HCC purposes, and then where provider education needs to occur. From a compliance perspective, I think provider ICD-10 training should be at the top of the list, if not at the very top, near the top of the list from training providers on ICD-10 coding. I think organizations do a great job on educating providers on CBT coding, on E&M coding, and making sure they understand the guidance and behind that. And I think ICD-10 coding, unless you're being reimbursed and paid based on ICD-10 codes, tends to fall to the wayside. And so incorporating some ICD-10 training, depending on your specialty, would be good from a compliance perspective. And with that, that brings us to the end of our presentation, and we've got about 9 minutes for questions.
Thank you so much, Carine. And we definitely have questions in the chat. So let me go back and start with our first one. We have several RHCs. Can you address the clinical and financial importance of HCCs, even though we are paid a flat fee?
So while you're paid a flat fee for RHCs and some FQHCs as well, I think the importance for HCCs is knowing that the claims that are submitted by your organization can be requested from the MA plan. So while you're not getting reimbursed directly, and that doesn't impact you from a financial perspective, the documentation can be requested because RHCs, the clinics they're submitting diagnosis codes on the claim to the payer. At the end of the day, the payer can come back and ask for that documentation.
Next question asks, what about critical access hospitals and RHCs? Does the MA plan not follow the cost report?
That is a really good question, and I don't have the answer to that, but I do have a reimbursement person at PYA that I can go back to her and ask for clarification on that.
So Diane, we follow up on your question and get back to you.
Yep.
Next question says, can you explain how this will affect telemedicine, as we have seen an increase in these services since the PHE?
Sure. Since telemedicine is still considered a face-to-face visit, it doesn't necessarily impact it to that extent. It would be the same kind of approach as to a patient being seen within the clinic or being seen within that physician practice or being seen at the outpatient clinic, whatever that may be. There's not a difference because it's still considered a face-to-face visit. And there was, and I'd have to find it, but there was guidance that came out during the PHE that indicated that HCCs, telehealth visits would still be able to support HCCs as long as certain criteria was being met.
Okay, and I think you might have just answered this, but I'm going to go ahead and present the next question. During the PHE, could providers submit codes that were not from face-to-face visits for HCC documentation purposes?
I know there was a period of time because if it was clearly documented that you attempted a telehealth visit and the patient didn't have video capabilities or you didn't have that the ability to see the patient, I'd have to go find the guidance, but I'm fairly confident in the early part of the PHE. I know things shifted and changed a lot, but in the early part of the PHE, you were able to use telehealth visits that didn't have like a face-to-face component, because CMS and the MA plans considered that telehealth as a face-to-face visit, even though you couldn't see the patient directly.
And next question in the chat states, just for clarity, you are saying if the providers refer a patient to a specialist, then we can use that for HCC, but documenting that we are reminding the patient that they need to follow up for a chronic condition is not?
That is correct. So a referral to another provider to say, I'm a primary care provider. I can't address your GI condition. I'm going to refer you to Dr. Smith at GI gastroenterology of Georgia or something. That can count from an HCC perspective, but if a patient already has a GI provider and you are just reminding them to schedule the appointment with their GI provider, that would not support from an HCC perspective.
And that concludes the questions we have in chat, but there were two that came in during registration, so I'm going to present those quickly. It simply states, how do you not upcode in this process?
That's a good question, because I think that's been the biggest problem for the MA plans. The way that you don't upcode is you're only coding to the highest level of specificity based on the provider's documentation. So you would not select a more specified code for, I'm going to use CHF because there's multiple components to it. So you wouldn't select systolic CHF if the provider just documented unspecified CHF. They didn't say anything else. They just said the patient has CHF. You wouldn't select a more specified code, which would be upcoding in a sense. You can only code what's in the documentation. So that's a way to not upcode. The other way is, I know some EMR systems, once you select a condition, it populates a code to go with it. I think that causes some problems for some organizations, but that's another way to make sure that you're not upcoding, that the providers are only selecting the code that for the service that they are providing and the condition that they are addressing.
Excellent, thank you. And final question that I see says, continue to have Medicare Advantage quality vendor like ACO push our providers to add all HCC's S codes to visits when encounter is for a specific issue and not a wellness visit. They want us to add codes that weren't part of the decision making. Any advice?
I would only add codes that are relevant to the visit that you're the provider seeing the patient for. I think what's occurring, probably the concern that you have is what the OIG is kind of finding within their audits, is that there's a lot of codes being submitted that are not supported by the medical record documentation. So only submit what the provider is documenting within that office note.
And I don't see any other questions in the chat. So I'm going to just kind of close by saying that the Texas A&M Health Rural Engagement Program can support operational and technical assistance needs to rural providers and healthcare organizations in Texas. And we do work with PYA and to do a lot of that work and provide education. So if you have needs around HCC risk coding, please inquire. We have a link here that I'm going to drop in the chat, and you can use this to request support. Unfortunately, this is only available to providers in Texas, so keep that in mind, but it has been dropped into the chat, and we thank you for your time today. We look forward to you joining us again next month on our next webinar, and a huge thank you, Carine, for your expertise and education. It was very informative.
You're more than welcome.
Thanks, everyone.
Thanks.